My name is Danielle Crookes, and I am a doctoral candidate in the Department of Epidemiology at Columbia University's Mailman School of Public Health in New York. I would like to extend a warm thank you to my collaborators for their work. Among adults, depressive symptoms are associated with higher rates of cardiovascular disease. However, the evidence is mixed regarding the association between depressive symptoms and hypertension, especially among young adults. The deleterious effects of some antidepressants medications on blood pressure may contribute to these mixed findings. In this study, we examine the relationship between depressive symptoms, antidepressant use, and hypertension among participants of AdHealth, which is a nationally representative longitudinal study of adolescents recruited at U.S. schools and followed through young adulthood. We utilized data from waves 1, 3, and 4, during which participants were 16, 22, and 29 years of age on average, respectively. The sample included 11,183 participants. Multiple imputation was used to address missing data. Depressive symptoms at each wave were assessed using an abbreviated Center for Epidemiologic Studies depression scale. Hypertension at age 29 was assessed using measured systolic blood pressure of 140 millimeters of mercury or greater, diastolic blood pressure of 90 or greater, or use of antihypertensive medications, which were staff inventoried at an in-home visit. The prevalence of hypertension at 29 was 20% in this sample. High depressive symptoms in adolescence or young adulthood were not associated with hypertension in young adulthood. On the other hand, depressant use without concurrent high depressive symptoms at age 29 was associated with increased prevalence of hypertension, even after adjustment for demographic and health behavior variables such as smoking. An interaction with sex was observed. In the absence of high depressive symptoms, men taking antidepressants were more likely to be hypertensive than men not taking antidepressants. There was no association observed between antidepressant use and hypertension among women. Selective serotonin reuptake inhibitor, SSRI, and use and non-SSRI antidepressant use were associated with hypertension, with a stronger effect among non-SSRI medication use. Our findings were robust across sensitivity analyses, including a complete case analysis. In the sample of adolescents followed through young adulthood, antidepressant use, not depressive symptoms, was associated with hypertension. Our study is limited by the use of an assessment of depressive symptoms, not an use of clinical diagnosis of depression at each wave. As such, we cannot discern whether the noted association between antidepressants and hypertension is due to a diagnosis of depression, where medication would be more likely to be prescribed, or is the result of the medication itself. Future research that makes a further distinction between high depressive symptoms and diagnosed depression, separate from medication use, would be important. Our study is strengthened by the inclusion of several young adult participants, which are typically underrepresented in this body of literature. Future research should continue to examine the joint and independent effects of depression and antidepressant use in larger samples of young adults.